Good morning. Hello, howdy, hi. Saturday, June 27th. Aaron Boster here, gearing up for the June Ask Me Anything live stream. I like to turn my camera on right at the top of the hour. At 11, I'll start taking questions. I like to turn this on a little bit early, though, just in case anybody in this growing global online village wants to join me and say hello, howdy, hi. There's Pink Meadows, almost always first to join us. Howdy, hi, great to see you. How's my audio coming in? Hey, Julie. Can you guys hear me okay? Howdy, frogs. Fantastic, Julie. I'm glad to hear it. Hey, Karen Tweed. Great to see you. As you guys jump online, share where you're jumping on from. I love to go back through the chat and read after I end the live stream and see where everyone came from. It's so cool. Glad that the audio is working. Hello, Sterling Guitar Ham. Hey, Cindy Jones. Orlando, Florida's in the house. What's your weather like down there? We've got 2 Floridians in the house. 3 Floridians. We got Florida all over the place. Look at that. Knoxville, Tennessee representing. Maryland's in the house. Ontario, Canada. Give it up. Beverly, Gahanna, Ohio. That's my hometown. I'm a Gahanna Lincoln Lion. Graduated from Gahanna. Born and bred. San Diego's in the house. What's going on, Vivian? Thanks for being here. New Jersey, what's going on? Hey, how are you? Greensboro, North Carolina. Super hot in Florida, I believe that. Winnipeg's in the house. That's fantastic. I'm going to go live at the top of the hour, of course. And in the meantime, are there topics that you guys would like for me to discuss today? I was kicking around a couple different ideas. I thought maybe we would talk about relationships in MS. I thought maybe we could talk about legitimate monitoring. How do we actually monitor your disease? Those were things that were sort of top of my mind, but what do you guys think? Mary's asking about trigeminal neuralgia. Sure, we can touch base on that. Just ask the question once I go live. There's some good questions popping up right now. Dallas, Texas is in the house. What's your weather like over there? Howdy, New Jersey. Great to see you, Sandra. Welcome, welcome, welcome. I'm going to put a chat question in here. All right, I just threw a poll in the chat. So take a moment if you don't mind and pick your preference. I just threw two potential ideas into the chat. Tell me which one's more exciting for you to hear about today. Would you rather hear about relationships in MS or about how we monitor the disease, or are neither of those topics exciting for you? A lot of great questions popping up in the chat. I'll turn my camera on at the top of the hour in just 25 short minutes. In the meantime, as you jump online, share where you're jumping on from. Say hi to your neighbor. These are wonderful questions. Make sure that you ask them once we go live. Where in Germany are you from? No camera. "21 votes, but there's 51 of you online with me right now, so if you haven't voted yet, please do so. Take a second and click which of those two topics are the most exciting for you. Greetings from Colonia, that's awesome. Omaha, Nebraska's in the house. These are great questions. That chat is still live. If you haven't clicked your response, please do so. Detroit Goldie, what's going on? Greetings in the UK. There's 35 of you that have jumped online. I'm loving that. This is Aaron Boster from the Boster Center for Multiple Sclerosis and Single Point Healthcare. Super excited to kick off the June Ask Me Anything live stream, where I'll answer your questions live about multiple sclerosis. Someone's asking about microdosing mushrooms on Tysabri. Those might be separate things to think about. Pittsburgh, Pennsylvania's in the house. What's going on, Denise? Someone's asking about Octave. Absolutely happy to talk about that. Great questions about Maven. These are super questions, guys. I'm loving them. Definitely make sure to repeat them once we go live at the top of the hour. Portland, Oregon's in the house. Retitriptide and Tysabri. That's a solid question. All right, there's 53 of you online. There's only 31 of you that have voted. If you haven't voted yet, do me a kind favor and click your preference. Which would you rather hear about today? Relationships in MS or how to monitor your disease? Prescott Valley, Arizona. What's your weather like over there? Hey, Kaylee in Colorado, what's going on? All right, I'm going to close the chat question here in just a minute or two. Right as Ben, one of our amazing moderators, has joined. Hello, Ben. Thanks for being here. Good, sir. Say hi to our moderators when they pop on. Their names are in blue, and they help make this live stream successful. So I really appreciate our moderators. They help me find questions and throw them up. Not your average pre-med. That's a funny name. I like that. Someone said they can't hear me. Are you guys having trouble hearing me? Can you guys hear? Hey, Kelly. Vivian can hear. All right, sounds like we're doing okay. Super, Ben. Thank you for that. Karen, we'll look forward to catching you on the replay, and I'll look forward to seeing you the next time we jump on live. Have a great rest of your day, and thanks for stopping by. Perfect, Allison. Kind of perfect weather. Look at that. You guys are jumping on to the June Ask Me Anything live stream. This is Aaron Boster. Super pumped to turn the camera on at 11 o'clock at the top of the hour and handle your questions live. These are some great questions showing up in the chat already. As you jump online, please share where you're jumping on from. It's awesome to see where members of this global growing online village have amassed from. Also, as you share your questions, please keep in mind that I can't diagnose or treat you on the interwebs. I don't have enough information. And so please make sure that your questions are generalizable so that everybody can benefit from it. Oh, that is so sweet of you to say. Thank you very much. What's going on, Terry? I hope you and yours are doing well. That's some nice weather, Ben. SDF 1714, that is an awesome question. I would love to answer that question when we go live. Wisconsin's in the house. .72 and storming. Yeah, it's a little rainy today in central Ohio. We've got just 17 minutes before we turn the cameras on and start to tackle your questions live. Joe Siders is in the house, another amazing moderator and all-around awesome guy. Joe, thanks for being here. Everybody say hi to Joe for me. Richard Cano has a great question. North Carolina representing. What's going on, Blue Eyes? That's some high humidity, Kay. Wow. Phoenix is in the house. Joe's reminding you that if you would like to help push this live stream out so that more people are alerted to it and more people can benefit from the information, hit the like button. You can pop out of the chat, hit the like button, and jump right back in. Also, just by your participating in the chat, just by your comments, it helps the YouTube algorithm know that this is something exciting and that others might like to hear about it as well. All right, guys, I'm going to go refresh my coffee. I'll be back in a few. Please say hi to your neighbor, pull up a good chair, make sure that you get some water for the MS Water Challenge, and I'll be back with you shortly. Howdy, hi, I'm back, coffee in hand. Hello, everyone. Aaron Boster here. Super excited to kick off this June Ask Me Anything live stream, where I'll be tackling your MS questions live. Oh, that's really nice of you, Remington. Thank you for the kind words. Some good questions about GLP-1s and MS. Happy to tackle that. Thanks, Kaylee. I love hearing that. Croatia. Where in Croatia are you coming from? I took an amazing vacation in Croatia just a few years back. It was phenomenal. Even so, it as well as in the house. Everyone say hi. If you don't know that lady, you need to. She's got an amazing YouTube channel, and she's a huge supporter of this channel, and I'm grateful to have you here. Yeah, I should change the banner, shouldn't I? Let me fix that, guys. Thank you for pointing that out. All right, thank you for catching that. Switched it over to June. I'm not going to quit my day job as a neurologist. Tennessee is representing. That's amazing. As you guys jump online, share where you're jumping on from. And as we start answering questions, please keep in mind that I can't diagnose or treat you on the interwebs. Please make your questions generalizable so everyone can benefit from them. This is Aaron Boster, kicking off a June Ask Me Anything live stream. Super excited to turn my camera on in 12 short minutes and start to tackle your questions. Grab a glass of water for the MS Water Challenge. Where in Scotland are you? That's awesome. Yorkshire, UK is in the house. What's going on, Helena? San Antonio, that's what's up. What's your weather like down there? It's got to be super hot right now. Not your average pre-med, that's a great question. Susan, I can't legally do virtual consultations. There was a period of time during the pandemic when those laws were liberalized and we could do some things like that. But since the pandemic's ended, it's no longer an option for us. So we oftentimes do televisits with patients in follow-up if I have a license in their state, but consultations have to occur in the office. Helsinki is in the house. What's going on? Dublin, Ohio representing. Hello, Robert. I hope that you and yours are doing well today. Great to see you. 10 short minutes until we go live. Get your questions ready. Loch Lomond. Grove City representing. What's going on? Michelle, it's great to see you. High five. Nine minutes until we go live. Oh, thanks, Giselle. That's really sweet of you. I appreciate you. Hey, Amy. Great to see you. Welcome, welcome. I agree with you. MS does suck. 9 minutes until I turn my camera on. Good morning, everyone. Sandra says, when do you have time to be a doctor? You spend so much time educating the world. MS must be your life. I see patients in clinic Monday through Thursday, and only recently have I started to use Fridays as an administrative day. Up until very recently, I was seeing patients in clinic 5 days weekly. So plenty of time to be a doctor. From 8 in the morning until 5 at night, I'm in my clinic helping take care of folks. Eight minutes until we go live. Thank you so much for being here. There's 65 of you that have jumped on already. That's freaking awesome. Thank you very much. Mansfield is in the house. Hello, Elizabeth. Thank you for being here. Seven minutes, guys. Hey, Steph. Welcome. Great questions today. These are such good questions in the pre-party. I may have to scroll up and kind of knock down some of them as we are kicking off, because I just like these questions a lot, guys. Six minutes. Good morning, hello, howdy, hi. Welcome, welcome, welcome. Aaron Boster here, representing the Boster Center for Multiple Sclerosis and Single Point Healthcare, caring for families impacted by MS from around the globe. Super excited to kick off our June Ask Me Anything live stream in 6 short minutes. Hello from Italy. Even So It As Well has reminded you guys that if you'd like, you can click that link there that we put out at the Boster Center for MS and at Single Point Healthcare, which updates you on the latest and greatest in research opportunities and what's going on at the center, and very importantly, it tells you when I'm going to go live. So if you'd like to have that information, feel free to click that button and sign up. It's completely free to sign up. You can update on when and where I'm live. That's a great way to do it. What's going on, Dean? Great to see you. Thanks for stopping by. 5 minutes until we go live. I agree, Joe. Bluthton's in the house. What's going on? Another outstanding moderator and longtime supporter of the channel, an OG, if you will. There's 96 of you that have popped online. It's starting to warm up in here. I'm getting kind of excited. We just crested 109. Giddy up. Welcome, Junior. Grab some water, my friend. Pull up a chair. We're going to kick this off in just 4 minutes. Welcome, welcome, welcome. 3 minutes. You know what that means, guys. It's time to flame up the chat. There you go. Ben's already got it started. Follow Ben's lead, please, and flame up the chat, guys. Something's a bit glitchy on my end, but flame up that chat nonetheless. There you go, guys. Now the chat's working. Let's get all the flames going. There you go. Ben's got it going on. Bluthon's got it going on. Elizabeth's got the right idea. Flame up that chat, yo. Show the YouTube algorithm that you're excited to be here. We are going to energize, empower, and educate in just a few short minutes. Detroit Goldie's leading the way. Mike's got it going on. Flame up the chat, guys. Spam that flame button. We've got 2 minutes until we go live. Fire it up. That's right. There we go. Let's kick it off. Tell the algorithm that you're here. Nice. Look at Joe. Thank you, my friend. Fantastic. That is exactly right. You got to get those flames going. We have 2 minutes until we go live. Virtual drum rolls are kicking off. We have 1 minute, less than 60 seconds. Don't stop the flames. We've got this. Seconds before we start. Don't stop hitting those flames, guys. Less than 60 seconds. Kicking off the June live stream. Staring at the clock. I can't wait to hit this button. Let's do this. Don't stop the flames, guys. Victoria's got it going on. Sue's got it going on. Sterling's got the right idea. Ben's got the right idea. Just a few more seconds. Yo. Drum rolls, bugle sound. It's on. Hey! Good morning. Hello, howdy, hi. Aaron Boster here, representing the Boster Center for Multiple Sclerosis and Single Point Healthcare. Super excited to kick off this June Ask Me Anything live stream, where I'll be tackling your questions live. If you're new here, thank you very much for coming by. I've been doing these live streams now, gosh, for 6 some years. It's super fun to get a chance to connect with you and get to field your questions live. It's also just a really nice community. And so I'm so appreciative of having all you guys here. There's 57 of you that have jumped online. Thank you to each and every one of you. Let's start answering some questions in the chat. All right. So this is a really important question asked by SDF 1714, who writes, "Hi, Dr. Boster. Well, howdy. What advice do you have for someone who has lost health insurance and is living with relapsing MS?" So the reality is that the American healthcare system is flawed. And if you don't have health insurance, it can make it a barrier to getting access to care. However, there's a couple things that I want you to keep in mind because we can treat your disease. A lot of doctor offices will allow you to pay cash for visits. And so when we have patients that don't have access to insurance, we can take cash and we can still see them. As far as getting medicines covered, you can get medicines covered even without insurance. And let me give you 3 examples. My favorite example is to consider participation in an MS clinical trial. MS clinical trials don't use placebos anymore, not in phase 3. And so if you enter into a phase 3 trial, you're put on an MS drug, and it's either drug A or drug B. And you might not know which one it is, but that's the experiment, but you're guaranteed that you're on a real drug. Also in the clinical trial, the visits are paid for by the sponsor, so you're not paying when you see your doctor and your medical team. Also, they pay for all your labs and monitoring, and they pay for your MRIs. And so one of the ways that you can actually get what I call tertiary level care, or really high level care, is by volunteering to participate in an MS clinical trial. And if you don't have access to health care, I think that's something that you might want to consider. Another option would be to use a generic version of an MS drug. I've talked on this channel before about how I don't prescribe Aubagio, branded Aubagio. The generic name for Aubagio is teriflunomide. I didn't make these names up. Now, there's an old rheumatoid arthritis drug called Arava, and it's cheap as dirt, and the generic of that is called leflunomide. And when you swallow leflunomide, Arava, and it goes in your stomach, the first metabolite is teriflunomide, Aubagio. And I can typically use good RX coupons and get someone Arava for about $20 a month, and it's an effective way of treating your MS. A third way to do it is if you apply for a medicine and you don't have insurance, oftentimes the pharma company will give you the medicine. Not all the time, but oftentimes they have programs where they're allowed to help you if you don't have access to healthcare. So do not hide. Please make sure that you go see your doctor and talk with them about these options. And even if you have to pay, say, cash to be seen once or twice a year, it's probably worth it to keep your MS in control and under wraps. Excellent, excellent question. By the way, MS Water Challenge, yo. When I drink, you drink. You know how we do it. All right, let's take another question. That was a good one. So, I'm going to butcher your name. Liz Sullivan asks, how crucial is it to get MS treatment, and how soon after the diagnosis? I think it's critical to get MS treatment if you want to control the disease. Unfortunately, behavioral measures alone, so diet, exercise, mindfulness, those things are important, but they're not adequate by themselves. If you want to make the MS boring, if you want to have an opportunity to live your best life despite having MS, we need a full court press, and that includes taking medicines, MS disease-modifying therapies, which alter your immune response so that you don't have your immune system attacking the holiest of holies, the supercomputer that runs the body, the brain, or the superhighway, the spinal cord that takes all the information from the noggin down to the feet and back up. And so we absolutely need to be on a disease-modifying therapy if we want to have the best chance of controlling the disease. How soon after diagnosis? It's not an emergency. So if you think about like a heart attack, God forbid, we need to treat that right now. And if you have pneumonia, we need to treat that today. If you're diagnosed with MS, I would like to see you start on treatment in the next couple months. If you are 3 months in and still not on a drug, I'm going to start to get a little bit anxious, slowly alter the immune response, and they do it for a really, really long time. So Sandra says, burning question. Can getting a concussion progress MS? Not just exacerbate the symptoms, but actually push you further along in the disease course? No, I don't think so. I think that if you smash your head, which is terrible, and you have a concussion, so you've literally bruised your brain, that can make the MS symptoms worse, and you can have two bad brain problems, which together will make you be more symptomatic, but I wouldn't think that the damage to the head makes the MS progress in and of itself. All right, let's look for the next question. So, how do I convince my doctor to prescribe MS meds? I'm 63, I just had an MRI. The doctor says that there's no new lesions, so I don't need MS drugs. I disagree. What do I say to convince this doctor? Well, you have a couple options. I would get a different doctor. I'm concerned that your doctor doesn't want to give you medicine. That's why doctors went to doctor school, to be able to doctor people. And so that's weird, and I'm concerned that that doctor's being ageist. 63 ain't old. And immunologically, 63 is not old. Your immune system isn't quieting down. And the fact that you didn't have a new spot is awesome sauce, but right now we're not doing anything to protect a new spot from forming, so that's concerning. So I would probably fire the doctor and get a new one, but let's pretend that you don't want to do that and you want to stay with the doctor. Then I would have an engaging conversation and I would say, listen, I understand that you don't think I need treatment, but it's my body and it's my brain and it's my insurance money and I'm paying to be here right now because I want you to put me on a therapy. And I think that's a fair conversation. If they say they don't want to, say, okay, that's fine that you don't want to, but I want to, and I need you to. And then if they still say no, then I would go find a different doctor. So Angela Long asks, are there any current studies looking at atypical MS patients to see if there's other forms? So on this channel, I shared the updates to the MS new diagnostic criteria, which we call the 2024 revised McDonald criteria. And something very important, actually several important things happened in those criteria, but one of the important things that happened in those criteria was being honest that many people present with MS not classically. So if someone presents with MS with an optic neuritis or a transverse myelitis, or a brainstem syndrome, these are very classic presentations of MS. But not everybody's classic. You're not a textbook, you're a human being. And what we've recognized is you can have different presentations. Someone might have a seizure and then they get an MRI and it looks like they have MS. They may have unusual headaches and they get an MRI and it turns out they have MS. And so we're making the diagnosis based on a biologic phenomenon, and we now recognize that there's different ways that you can come into it. And so this kind of speaks to this concept of atypical MS patients. I think patients are people and they're varied. There's 104 of you that have jumped online. The second I said that, it jumped to 85. My point is I'm really appreciative that you guys are here. Thank you very, very much. Let's change up the scene. This is the river scene. It's kind of nice. And let's take another question. So Mitchell Wong asks, does a subclinical lesion of the right optic nerve lead to a retinal tear and detachment? No. Now this can be confusing because you think of the eye as one thing, but really the eye has like a gazillion different parts. And where the retina attaches and where the optic nerve is really, really far apart from each other, speaking about the eye. And so they're not really related. Optic nerve damage won't have any direct impact on the retina or vice versa. Looking for some more questions? Jenny B, representing Ohio and Springfield. What's going on, Jenny? So KD says, what's the best treatment for MS slowed digestive system? And this is an important point because people with MS tend to have slowed gut motility. Not everybody, but I see it commonly enough. And people with MS, interestingly, have something called dysbiosis, which is a weird word. The flora of your gut is lined with bacterial flora on purpose, and they're healthy bacteria that help process and digest your food. And for reasons that are unclear, people with MS have abnormal gut flora. And I think that, at least in part, this could contribute to why we see slowed gut motility. One of the things that I'm a big fan of is being proactive, particularly as it relates to pooping. And there's a couple things that I think are really, really helpful. One of them, of course, is water. So MS Water Challenge, yo, when I drink, you drink. You know how we do it? That's delicious. Being dehydrated makes poop harder, and it increases the risk of constipation, and it can make it harder to move your bowels. Staying hydrated is really, really important. Your colon's about 7 feet long, and the purpose of the colon is to suck water out of the stool to keep it in your body. If you're not getting enough water, you're gonna make a rock, and it's gonna be really hard to pass. And so upping your water game surprisingly can help a whole bunch with slowed digestive system. Number two is to consider the foods that you're eating. Certain foods may contribute to slowing your gut motility, so sometimes people need to stay away from certain things like heavy meats and cheeses and nuts and things like that. Another thing that you can do is you can take a probiotic. So remember how I was talking about the dysbiosis problem? You can replace the gut bacteria with healthy gut bacteria by swallowing them. And so when you buy a pill of probiotics, it's a couple billion bacteria, specifically healthy gut bacteria. And so that can actually help gut in the setting of MS. Likewise, I like people to take fiber. Fiber is an indigestible solid like sawdust. And when you eat fiber, it acts as a sponge, so it helps hold the water. And when you have stool plus water plus fiber, you make a big bulky stool that's easy to hold onto and easy to pass. Also, the microbiome, the gut bacteria, they don't eat steak, they eat the fiber. And so you're literally feeding them, and then they'll do a better job of processing your food typically. So those are some things that you can do. Another thing that you can do is you can time bowel movements, and I find this to be very useful with my patients. There's something called the gastrocolic reflex. So gastrocolic, when you put something in your mouth and it hits your belly, particularly something warm, about 15 to 20 minutes later, your bowels try to release, and that's a reflex. And what that means is when you wake up in the morning and you have your first cup of coffee, and that warm coffee hits your belly, 15 to 20 minutes later, your colon's going to try to move. If they can't move, or if they do move, that's the best window when it could happen. And so what I would recommend you do, even if you don't feel it because the MS doesn't allow you to sense that you need to move your bowels, 15 minutes after your coffee, go sit on the john. Now, if you want to kick that up a notch, you can try digital rectal stimulation. And sometimes people go, ooh, but come on, we're trying to have a bowel movement. You're in the bathroom by yourself. You always have your fingers with you. You can wash your hand when you're done. Insert the finger in the rectum, move it in a circle, and it stimulates all these nerve fibers that go straight up to the spinal cord, which basically says like, hey, hey, and tries to get the spinal cord's attention and say, it's time to poop now. So these are all things that we can do to try to help move your bowels. That's a great question. Thank you for asking. So here's a question that I saw earlier during the pre-party. This is a portion of that question, asking about old lesions growing. So when you have an MS lesion, the lesion is really an area of inflammation where your immune cells left the bloodstream, they've entered the brain, and they've kicked off an inflammatory cascade where they're thinking that they're fighting a bad guy, except the thing they're fighting is your tissue. And that results in some cell damage and a puddle of water forming at the microscopic level. And that looks white on an MRI. Now lesions, they grow and then they can stop growing, right? And so they can have a certain size. Sometimes a lesion can reactivate and then it'll grow more. Or sometimes you'll hear us talk about a smoldering lesion, which is very slowly growing over time. And this correlates with bad things. An enlarged lesion, to me, is the exact same thing as a new lesion. And smoldering lesions, like we've talked about, are probably some of the underpinnings of progressive disease states. So that's an important topic. Let's see here. Trying not to lose the questions. Joe Siders is reminding everyone that I have a few videos on my channel, probably over, I don't know, 1,100 or something. I've tried to create playlists. So if you are interested in a particular topic, click on the playlist button on this channel. And there's a bunch of playlists, and I've tried to group the videos that way to try to help you find them. Jenny, this is an awesome question and very germane to my practice because I use a lot of alemtuzumab Lemtrada in caring for people with really aggressive MS. And so this question's a really good one. Lemtrada back in 2018, stable. Am I considered covered from a DMT standpoint? Maybe. So when you take most medicines, you take them on a continual basis. So for example, I take a cholesterol medicine every single day. And if I stopped my cholesterol medicine, my cholesterol levels would go up and I would increase my risk of heart attack and stroke, which is bad. So I keep taking it every single day. Not all medicines are like that. Limtrada, alemtuzumab, and another MS medicine called Mavenclad or cladribine are two examples of discontinuous medicines. So these are medicines that you don't take on a continued basis. You take them for a period of time and then you don't take them anymore. This is unusual in the setting of MS, but it's actually very common in other fields like in oncology when you're treating a cancer. So you give someone Limtrada and it's infused in the vein for 5 days in a row. So Monday, Tuesday, Wednesday, Thursday, Friday. And then you don't treat them for a full year. And then on the anniversary, you treat them for 3 days, Monday, Tuesday, Wednesday. And then you don't treat them ever again unless they have new disease activity. So how does that work? What it's doing is it's not blocking cells, it's rebooting your immune response, the adaptive immune response. The B and T cells take a big hit, and when they come back more well-behaved, which is an interesting trick. Once you train them to be more well-behaved, you probably don't need to remind them very often. And when I'm explaining this to families, I like to use the example of my dog River. So when River was a puppy, she thought it was cool to get on the couch. And so she'd jump on the couch and I'd yell, no, and I'd rip her off the couch. And then she'd get back on the couch and I'd say, no, and I'd get her off the couch. And she learned really quickly that getting on the couch was not awesome, that every time she got on the couch, something bad happened. And so she learned as a puppy not to get on the couch. And I'll point out that I didn't have to kill my dog or build a fort around my couch or remove the couch or dig a moat. I just taught her not to do that. And then afterwards, she didn't do that. Now, every once in a blue moon, she might get on the couch, and then I just need to remind her once, no, get off the couch. And then she remembers not to do it again. Now, your immune system's not a dog, but there is an analogy here because we're trying to do something similar with your immune response. Once we retrain your immune system to knock it off and not attack you, we don't need to redose. And then the question becomes, for how long? Because if you look at the data, going out 10 years, over half of people have started to have disease activity again. And so the question becomes, well, how do you monitor that? And this was actually one of the questions that I wanted to talk about today, so let's talk about it. How do you monitor someone to know if what's going on is working? Whether it's because you took Limtrada in 2018 and now you're not on anything, and are you still covered? Or how do you know that your Ocrevus that you're taking every 6 months is working, or your Tecfidera that you take twice a day is working? How do you do that? It's the same for Limtrada as it is for the other medicines. The monitoring is the same, even though with Limtrada you've been treated and now we're just seeing if things are still okay. The monitoring doesn't change. So, in fact, I think the monitoring maybe becomes more important when you're out this far out past Limtrada because we want to catch things if need be. So, how do we do that? Number one, we talk to you. Right? You're a you expert. So Jenny knows more about Jenny than any other human on Earth, which is pretty remarkable because there's 8 billion people and Jenny is the world expert on her. So if we ask Jenny about how she's doing, she'll tell us. And we want to pay attention to the litmus test of life. Now, obviously, if you're having an attack, that's kind of a no-brainer. Things are not going well. But you also might be slipping. I don't mean slipping physically, I mean slipping in the litmus test of life, and some things are becoming harder and symptoms are starting to come out, and we need to talk about that. That might be a factor telling us that we need to retreat. What else could we do? We can examine you. We can run you through the MS Olympics, as I joke, and we can look to see if there's evidence on exam that things are starting to get worse. That would be another tip-off that maybe we're not controlling the disease the way that we hope to. A third thing that we can do is we can get MRIs. And I think it's important to get an MRI of your brain once a year after you've had Limtrada or if you're on any drug, because I want to look, quote, under the hood, quote. You're not a car. But I want to look at the brain and make sure that I'm not seeing any new structural damage. If we see an enlarged lesion or a new lesion or an enhancing lesion, that ain't okay. And to me, that means the same thing as an attack. It means that your disease has started to reactivate. Now, when we did the Limtrada clinical trials, the CARE-MS1 and the CARE-MS2 trials, if someone in the trial got the first year of Limtrada, then the second year of Limtrada, and then they were being followed, if they had 2 new spots on MRI, they were allowed to be redosed in the context of the trial. And I certainly have retreated people because we've seen new disease activity radiologically. Another element that I think is really, really helpful is the octave test. And a couple of you in the chat had asked about the octave test, so I'm happy to talk about it. The octave test is, in my mind, the first commercially available, reliable biomarker blood test to tell us how active your MS is, which is really, really cool. Now, the way this test works is interesting, and I've made some YouTube videos on this channel where I kind of talk about it in some detail, but just briefly, we draw blood, and the blood tests are looking at 18 different biomarkers. These biomarkers, these blood tests, teach us things about brain integrity, axonal integrity, inflammation levels, and when you add them all up into one score, which is called the MS Disease Activity Score, so DA for short, it then creates a scale 1 through 10. 1 is the goal. That's no discernible inflammation at all. Anything above 4.5 is bad. In my mind, that means that you have moderate inflammation. And if I gave you Limtrada, I don't expect you to have moderate inflammation. If it's above 7.5, that's very concerning. And that would actually predict attack or new spot on MRI. So, I'll give you an example of a dear patient of mine, a gentleman that I've taken care of for a long time and I really like very, very much. Smart gentleman. Very, very committed to living his best life, exercises religiously, got Limtrada years back, and has done very well. And we've been following him for years and years after his Limtrada, just killing it. Really not having any clinical difficulties at all. MRIs have been stable like Mabel. His exam's not changing. But we got an octave, and the score was elevated. The score was, if I'm remembering, like 6.5. And that didn't sit well with us. And so we had a discussion, and we chose together to reinitiate a therapy. Now, I don't think the gentleman's going to go back on Limtrada this time. He may take a different medicine. I think he may actually go on Ocrevus. But the point is, the monitoring worked. We identified that there was a signal that something ain't right, and then we were able to act on it. And I like the fact that we identified the signal pre-clinically. So we did it before the guy had an attack or his exam got worse or he had new spots. So excellent question. Thank you for asking that one. So Rachel asks a question about a drug I'm very fond of, Tysabri, natalizumab, or Teruco is another brand of natalizumab. And this question reads as follows. After 2 years on Tysabri with a low JC virus antibody positive status, is it a good idea to change from 4 to 6 week dosing to potentially keep risk of PML lower? Or do you allow staying Tysabri as long as possible? Does this track? Yeah, it does track. So everything in medicine is a risk versus benefit. And so we have to consider the risk benefit of the medicine, and we have to consider the risk benefit of the disease, right? So Tysabri's risk benefit is interesting. It's a very, very good medicine. It's a highly effective medicine. It has one big chink in its armor. If you have been exposed to the JC virus, and half of adult humans have been exposed to this virus, it's a dumb little virus. It doesn't normally hurt us at all. But if you've been exposed to the JC virus and you take Tysabri, there's a very, very small risk of a potentially fatal brain infection. So I said it that way on purpose because it's scary. A brain infection that could kill you is nothing to sneeze at. But the risk is very, 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 very small. And when I say very, 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 very small, in many people that risk is 1/100th of a percent. In some people it's 1,000th of a percent. Now, in certain situations that risk certainly can go up. And there are situations where it can go up as high as 1%, which is very, very high risk by comparison. So what do we do about that? Well, some neurologists, if you're JC virus antibody positive, they don't want to give you Tysabri at all. They just want to avoid that risk. And I'm not one of those neurologists. I don't agree with that. I don't think it's my right to tell you that you are or are not comfortable with something. I'm not in a position where I get to be paternalistic and inform you of your risk tolerance. That's your business. Instead, I view my responsibility medically and ethically as making sure that you understand the risk to the best ability that I have to explain it to you, and then to listen to your answer. So, if I tell you that you're eligible to be on Tysabri and that you have a low positive JC virus, and your risk is, we could calculate it, let's say it's 0.02%, you're allowed to tell me whether that scares you or not. And if you say, I'm scared by that, then we don't put you on that drug. And if you say, Aaron, I don't care, I say, okay, then we do that. And I think about a dear patient of mine who is a retired physician. And so you can't tell me that she doesn't understand medical risk benefit. She was a doctor. And she's been on Tysabri for a really long time, and she is a low JC virus antibody positive patient. And years ago I said, hey, are you okay with this? And she smiled and said, honey, when the risk is 1 in 10, call me. And that always makes me giggle when I think about that. Now this question is very intelligent because there's a way of mitigating the risk as opposed to just not offering the drug, that we can decrease the risk of PML simply by spacing out the infusions. And so there was a study done that wasn't really a study. It was a giant observation where a bunch of friends of mine that are MS neurologists enrolled patients who they were giving Tysabri to, and some of them were getting Tysabri every 4 weeks. That's the way the drug was developed, every 28 days. Other patients were getting infused every 5 or 6 weeks, so slightly more delayed. And it was a really large study with thousands of people being followed. And what they learned was awesome. There wasn't an increased risk of attack if you spaced the infusions out to 5 or 6 weeks. So there was maybe 1 or 2 people that had new MRI spots, but there was no attacks. And so the thought is that spacing it out to 5 or 6 weeks doesn't unbind your receptors so much that it makes the medicine not effective. So that's important. But when we looked at the 2 groups, the group of patients that were on every 4 weeks, in that group there were a couple people that developed PML. In the group on every 5 to 6 weeks, no one got PML. And so the conclusion was that that might be protective. So would I offer you to stay on Tysabri? Yes, if you understand the risk. Would I offer to space it out to every 6 weeks? Yes, I would. I do that in my clinic routinely. I also think if you don't have to come in every 4 weeks, let's not make you do that. One caution is that you can go too far. So 4 weeks copacetic, 5, 6 weeks copacetic. If you go out past 8 weeks, then you can start to have a problem. And after 8 weeks, you can unbind your receptors. And that's a very scary thing to do, because if you just stop Tysabri cold turkey, so going off 8 weeks would kind of be like going off Tysabri cold turkey, then the barrier that prevented your cells from entering the brain is removed, and they can bum rush the brain. And that can cause a very scary thing called IRIS, immune reconstitution inflammatory syndrome. And that's like a very, very serious multifocal attack that typically lands you in the hospital. So that's just a word of caution. Very good question. So Julie asks, can a functional electric stimulation device like a BioNS activate the underlying undiagnosed conditions? I don't think so. Even so it is well, says she loves the river scene and it makes her think of river. Thank you. I miss her. All right, so here's a question from Savannah Knight, who writes, diagnosed with relapsing MS 6 years ago. My neurologist says my symptoms sound like they're shifted to progression, but doesn't want to change the diagnosis because that would be bad. Why? Does the treatment method change? That's a really good question, and it has nothing to do with medicine and has everything to do with greed and the way that our insurance companies work in the United States. So there's situations where certain insurance companies may opt not to cover a medicine if you're labeled as having secondary progressive MS, which, excuse my language, is complete and utter bullshit, but it happens. And so sometimes a neurologist might not want to say that it's specifically secondary progressive MS or something like this because they don't want to risk that happening to their patient. Now, the reality is that it's the same disease, right? The new diagnostic criteria make that very clear, that whether or not you have progression or whether or not you have relapses, it's the same biologic disease. In the same way that one person with diabetes could go blind from diabetes and someone else with diabetes has normal vision but lost their kidneys, same disease. And yet, because we have created all of these labels used by insurance companies will sometimes try to play a financial game and try to say, well, we don't approve that for this flavor of MS, only for that flavor. If you have a history of relapses, you have a relapsing form of MS. And I don't have any issues with your doctor whatsoever remaining the label of relapsing MS. And it makes sure that options stay available to you. So I think I understand why they're doing that. 4QMS is on the line, wonderful moderator, wonderful guy. He's got a really nice YouTube channel and comes up with super awesome, creative, nutritional ideas. So check out his YouTube channel. All right, so Capturing Serenity writes, hello, Doc. Well, hello. Let's change the scene up as we answer your question. We're going to go purple. So the question is, I got my first half infusion of Ocrevus last week. Second half is scheduled in July. After that dose, I'm feeling very sleepy and lazy. Before infusion, I was actively going for a walk around 5K. So I think that we have to give a little bit of grace. And when you're getting these medicines, this is a pretty big deal. And so I'm not nervous about hearing that. And I would give it a little bit of time. I fully expect you to be back walking, and I wouldn't view this as a negative as it stands. So Biotechno writes, I have a very large lesion on my spine, so big that my neurologist thinks it's just a blurry image. Is this normal? So we should be able to sort that out, because when you obtain an MRI, they show it to you in different angles. So you can have a front view, a side view, a top view. And if you have a lesion on your spine, we should be able to confirm that on different angles. So if it looks kind of weird on one angle, we'll slice through it and we should be able to characterize it better. If the neurologist isn't sure, the neurologist can call the radiologist and say, hey, radiologist, what do you think of that lesion? And the radiologist will look at it again and clarify it. So that's kind of helpful. All right, let's look for some more questions here. So Mike writes, I have MS and untreated TB. Are there treatment options that would not activate full TB? Yes, there are. So first of all, you might want to be treated for your latent TB. Second of all, there are medicines that are immunomodulatory. They don't suppress the immune system, they just tweak it. And those would probably be safe for you to take. So for example, Vumerity and Tecfidera are immunomodulatory drugs. For example, Copaxone is an immunomodulatory drug. These are medicines that alter the immune response, but they don't suppress the immune response, and so they would be safe to take with an infection like TB. PHKC writes, is Kesimpta a good option if I'm concerned about PML? Yes, it is. All right, let's see what else we've got going on here. So Allison asks a question about GLP-1s. And so GLP-1s have become, dare I say, popular. They're utilized extensively in more and more indications. The GLP-1 is interesting. It was first identified from the venom of a Gila monster, like those giant lizards that can be really scary looking. And some of the venom did something really weird metabolically. And fast forward a bunch of years and a bunch of science, they found that it would help with diabetes. And it does two things in the body that are interesting. It slows gut motility, and it changes the brain chemistry so you're satiated. And as a result, people end up losing a lot of weight. And it turns out that this helps with a lot of different conditions, not just diabetes. And it's a remarkable weight loss therapy. So this has been looked at in the setting of MS, and at the Consortium of MS Centers Congress just this last month, I think, I attended a really nice lecture which kind of discussed this at some length, and so that was really educational for me. And I think I now have a better understanding than before. The data looks like it is safe for people impacted by MS to receive a GLP-1. So that's the first thing that I think is very important. So I don't think that there's any concerns if someone wants to take one that they have MS that would create a problem. The interesting part is that it might actually be helpful in the setting of MS. And this is now starting to be studied. There's a clinical trial which is gearing up where we're going to be trying to answer that exact question about whether we can see benefits to MS objective outcome measures with someone on a GLP-1. So that is being studied, and pay close attention. So Raj asks, can someone suffering from PPMS get married? Yes. So Meter Wing, I didn't pronounce your name correctly, I'm sorry. But this is a great question. I got laid off from my job almost 2 months ago and got Ocrevus infusion until last Sunday. Is there any risk due to this delay? Typically, no, there's no risk. The reason I say that is, sorry Ahmed, thank you for that. The reason I say that, let me get to the question, is because the way that the B-cell medicines work, they last a long time. Let me explain. When you take Ocrevus, the medicine within very, very quick time kills adult B cells, and so the levels of the B cells go down. Your body will make more adult B cells, but they don't do it really fast. So oftentimes when you first start on Ocrevus, at 6 months the B cells can start to come back, which is why we give it every 6 months. However, after you've been on it for a minute, meaning say like a couple years, your B cells don't come back as quickly. And so oftentimes we have found that we might even be able to wait and not infuse you exactly at 6 months. We might be able to wait 7, 8, 9 months before your cells start to come back. So interestingly, if you're not able to be dosed exactly on time with the B-cell depleter, it matters less. Now, that's not true with all the B-cell depleters. I'm talking about the infused medicines like Briumvi, Ocrevus, Rituxan. I don't think that you can play that same game with Kesimpta because the half-life of Kesimpta is shorter, so don't try to do that with your shots. So Billy West says, Dr. Boster, the reason I asked the octave testing question before treatment is because I was inquiring about it with my neuro, and she said that it's only to monitor how treatment is working. That's not true. That's inaccurate. So it doesn't monitor if treatment's working. It monitors MS inflammatory activity. So whether you're on treatment or not, it's going to measure that. And I use this when I meet a patient as a baseline for where we're starting. For example, someone's newly diagnosed and we get an octave, and let's say for the sake of the discussion that it's elevated because they haven't started therapy yet. So let's say it's a 7.5. We put them on a therapy and then we repeat that, and I demand that that goes down below 4.5. And so getting that piece of information is useful. It's not just for monitoring treatment response. Again, the thing that I would probably say to your doctor is, hey doc, I would like to do it anyways, and I'm the one that has to pay for it, so it's my blood and I'm willing to give it. It doesn't cost you anything to do it, so let's please do it. Greece is in the house. That's awesome. Where in Greece are you calling in from? So Raj is asking, says their son has PPMS, it's been on Rituxan, being dosed once in 6 months. Yeah, that's the way that I like to give it, once every 6 months. So that sounds really good to me. All right, let's look for a new scene. And there's 152 of you online. That's awesome. Thank you. So here's another Limtrada question from Todd Jones, 630, who writes, Dr. B, I am 10 years post-Limtrada, and it's caused hyperthyroid but stable MS. Is that because the immune response been directed to my thyroid versus attacking the myelin? That's a good thought, and no, that's not why. So Limtrada has a very well-described side effect profile. One of the things that Limtrada can do is it can cause autoimmunity. So you have an autoimmune condition, multiple sclerosis. But when you take the drug Limtrada, it can cause autoimmune thyroid disease. Or it can cause a couple other autoimmune things like autoimmune kidney disease, autoimmune liver disease. And it's not because we redirected your immune system to attack the thyroid instead of the MS. It's just a side effect of the medicine. Now, I'm not trying to make light of you having a problem with your thyroid because, it's your only thyroid. But I do like to remind patients that you don't need your thyroid to live and that we can supplement with pills to take care of the thyroid's function. It's not that easy to take care of MS in the same way. And so in the hierarchy of need, I would rather make the MS stable, even if it did hurt your thyroid, as long as we can manage that. I'm not trying to make light of the side effect, but I'm glad to hear that it worked to control your MS. That's awesome. So Zara Mohammed writes, Doc, is it okay to switch from Ocrevus to rituximab? Was diagnosed last year in January. I took my first Ocrevus in January this year. I'm due for my next dose in July. Yes. Ocrevus and rituximab are very, very similar. And the differences have to do with the tolerability in the human body mostly, not in the biologic effects per se. And so if one of my patients was on Ocrevus and then they had to take rituximab, I wouldn't be worried that I was going to throw their disease into a tailspin. Not at all. All right, let's change up the scene and take another question. This is the tablet scene. Bavaria is in the house. That's an amazing place in the world that makes some of the best beer I think that exists. That's my opinion. Greetings from Bavaria. On Gilenya since 7 years. No lesions, no relapses since 5 years. Should I stop taking the med? No, do not stop taking the medicine. Don't do that. I'm 57. What would you recommend? Is there a newer medication? So you're on a medicine and you're responding to your medicine, and I think that's awesome, and I would not stop your medicine. If there were side effects or if there was a risk, for example, let's say the Gilenya was hurting your liver, then we would have to change to a different medicine. But I wouldn't stop medicine, because if you stop medicine, the risk is that you're gonna have lesions and you're gonna have attacks and you're gonna have progression, and we've worked too hard to let that happen. So keep on keeping on. All right, let's look for another question. So Jimmy Micah writes, 4 years on natalizumab, taking it every 6 weeks, always positive JC virus, but low positive, 0.4 is considered low. Doctors thinking of changing to ocrelizumab or alemtuzumab. I'm excited about the second cause. I'd be free from meds. Thoughts? If you are thinking about Tysabri, Ocrevus, Limtrada, you're thinking about the 3 most effective drugs that currently exist to treat multiple sclerosis. So that's kind of like 3 supercar owners arguing about which supercar is better. The Ferrari, the Lamborghini, the Bentley. They're all really, really good. And so I love that you're having a discussion about changing within the highest rank of efficacy. And if you randomly picked one of those 3 drugs, you're picking one of the best 3 drugs that exists. I'm biased, and I really like Limtrada. Like me personally, Aaron, I think Limtrada is a really great therapy. And most patients don't agree with me. Most patients do not want to do the rigor of taking Limtrada. It's a lot of upfront risk and complexity in exchange for possible quiet disease down the line. But I think that's really cool. And so I would be very excited to give you alemtuzumab if that was a good fit for you. And I have a bunch of YouTube videos where I talk about Limtrada for people that want to hear more about it. All right, let's look for another question. SD Courage 27 asks, DMT for Crohn's and MS, is there one that could help both? Yes, Tysabri. So natalizumab has an FDA indication for Crohn's disease and for MS. And so when I have a patient with MS and Crohn's, I always like to give them Tysabri or Teruco. So Alex Johnson 6574 asks, are there any other pre-meds for Ocrevus besides IV Benadryl? I have had a slight reaction with Benadryl. Yeah, there's a lot. So IV Benadryl could be given orally, or you can use a different H2 blocking type medicine. You could use Zyrtec or Claritin. There's a lot of different ones that can be given. We have some patients that don't receive any Benadryl, and they do just fine. Is there a way to lower your JC virus number? No. Oh, that's nice. So Andrew Bruce just jumped on and said, hello, Dr. Boster. Howdy. Checking in from Galva, Kansas. Thank you for doing the live stream. I love watching. Well, thank you for being here, and I really appreciate you saying that. So 4QMS is making it easy. He found the link and threw it up there, so you can click on that if you want to learn a little bit more about Limtrada. So Milad DF says, what about Kesimpta? And Kesimpta is also a highly, highly effective drug. It's on the same shelf as the drugs that we've been discussing. I'm not going to be able to pronounce your name. Jala 1979 writes, stress has been extremely high. I've been pushing myself. Work added more to my plate, and it's affecting my memory, response time, etc. Work won't take no for an answer. Can FMLA paperwork help with this? Yes, 100%. This is a very, very important thing, so I'm really glad you asked that. And I'll start by sharing with everyone that I've made a YouTube video on this topic. So if you're not familiar with FMLA, the Federal Medical Leave Act, or the Family Leave Act, excuse me, Family Medical Leave Act, then I want you to watch that YouTube video so that you can fully understand it. The Family Medical Leave Act is brilliant, and it's an institution created by our federal government to protect you in two important ways if you have a chronic condition. Number one, if you have Family Medical Leave Act and it's active, the employer is not allowed to punish you if you have to do something medically. So if you have to leave work on a Wednesday to get an infusion, they can't fire you for that or give you a demerit or write you up because you have to go for your health. Now, they don't have to pay you money when you're not there, but they're not allowed to punish you for going. And it's not just for a doctor's appointment. It can also be for respite. I have some patients, they literally need a day off because they can't function. They have to spend the day resting in bed, and that's acceptable. And it's not only limited to that. It's also available so that you can take a family member to a doctor's appointment or to the hospital or things like that. But that's not the extent of it, and that's not where this will be the most helpful. The Family Medical Leave Act also mandates that your employer must give you reasonable work accommodations. And so what I would recommend in this situation is, number one, apply for FMLA. You have to work in the same place for a year. You have to work at least 1,250 hours, which is like full-time work. There has to be at least 75 employees in the company, and you have to work within a certain proximity of where those employees typically are in order for you to qualify. And you don't have to figure all that out. You can literally just call your HR and say, I want FMLA, and they'll walk you through it. Once you get the FMLA, then you go to your MS neurologist and you say, hey, I'm having these problems and my MS cognitive issues are exacerbated by it, and so I need a reasonable work accommodation. And then you and your doctor can kind of craft what that might be like. For example, I'm making things up as I speak. For example, we might say, okay, you have to not be forced to stay beyond a certain hour, or you have to be afforded more time on a given task. So that absolutely can help you. It is close to the top of the hour, and I'm going to wrap up, guys. I want to thank all of you for sticking it out with me today. There's 168 of you that are still online. Thank you very, very much. My name's Aaron Boster, representing the Boster Center for Multiple Sclerosis and Single Point Healthcare. And this concludes our June live stream. I'm going to be doing another live stream in 3 short months. We're going to be doing them quarterly moving forward, and I'll look forward to seeing you then. I also am really excited for you to continue to interact with me on my videos. We're putting out a video every other Monday, And my favorite would be if I get to see you at the Boster Center for MS. Until then, this is Aaron Boster saying be safe and take care.